In this episode of the ASC Podcast with John Goehle, we discuss the latest news, review common infection control and sanitary environment issues in ASCs, and in our focus segment, discuss navigating the complexities of ASC billing and coding with Bob Lathrop from SIS.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, SIS. SIS's mission is to deliver solutions and services that help surgery providers, regardless of care setting, improve their organization so they can deliver the highest level of care to their patients. For more information, go to sisfirst.com.
Welcome to episode 264 of the ASC Podcast with John Goehle, recorded on December 16th, 2025 from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry, and he is a highly regarded speaker on topics related to regulation, accreditation, and financial management.
So from all of us at the ASC Podcast, we're, of course, wishing you all a happy holiday season. Sue, a lot of things going on right now as we come to the end of the year. Hopefully everybody is getting prepared for all that end-of-year stuff and making sure that they're preparing for all the work that will no doubt occur in January as you do your annual meetings, annual education programs, et cetera. A couple things that I've just been noticing recently. We've had a pretty big increase in the number of requests for office-based surgery accreditation assistance. And I was thinking, Sue, that kind of has an impact on our ASC listeners here. Because we know that OBSs are one of the main competitors for ambulatory surgery centers. So it really behooves all of you to kind of keep an eye out on what's going on in your community with office-based surgery. We really know that in the next couple of years, office-based surgery is going to supplant some of the types of procedures that are currently being done in an ambulatory surgery center. Of course, that's been happening for a number of years, but there are some talks about, as we've mentioned before, cataract surgery moving into the OBS environment. We already know that some of the GI procedures are becoming very common in the OBS setting, and of course, pain management procedures there also. So given the increase in the number of requests that we're getting for OBS, I think you really should be keeping a very close eye on what's happening in your community. Get to know the competitors so that you can be prepared for whatever they might be up to. Sue, why don't we talk about some of the recent news?
There was an article in Becker's ASC Review about cost pressures that battered ASCs in 2025. So one of the biggest financial challenges for ASCs is, of course, the cost of staffing. And according to a survey done by OR Manager, 43% of ASCs reported operating budgets of $3 million or more in 2023, which was up from a reported 32% in 2022. Staffing is a challenge as ASCs try to compete with hospital pay rates, especially in the higher cost of living areas like New York City. Another challenge that has gotten worse since the pandemic are supply costs. The supply chain disruptions during the pandemic and the increase in new technology, which, there's a lot of exciting advances, but they also add to the costs. So the medical supply chain costs are projected also to increase by 2.41% in 2026. And something we've talked about a lot, not surprisingly, anesthesia coverage is a big financial issue for many ASCs. According to a VMG Health report, 44% of ASCs expected to pay anesthesia stipends in 2025, while only 28% did in 2024. The gap between what payers will reimburse and the true cost of anesthesia providers is only growing larger. So this is going to continue to be a challenge going into the future. And lastly, there are always challenges with payer reimbursement rates, and competition with hospitals is going to increase as more cases move into the outpatient space, and the hospitals really
trying to
don't want to lose.
Yeah,
they don't want to lose those cases because that kind of keeps them afloat. So.
Yeah, I mean, I don't think any of this is a surprise in this Becker's article, but just another area. I just got off the phone before we recorded with one of our clients who's talking about how expensive the salaries expenses have been for the nursing staff and how difficult it is to recruit nursing staff at this point and to be able to afford to pay them. And as you pointed out, Sue, in the major urban areas in which the surgery center is in, it's even more difficult because they're directly competing with hospitals who have a lot more financial resources to do that. I think going into 2026, anesthesia is going to become an even larger issue right now. And I've seen enormous stipends being paid to anesthesia providers, if you can even find the anesthesia providers. And as we've mentioned before, I think we're going to also see changes in the way we're providing anesthesia service. I think we're going to find much more requests for CRNAs. I think we're going to see conscious sedation, RNA-administered conscious sedation, coming to the forefront again. All of those things are options that you should be considering when you start to experience some severe anesthesia problems. So one of the things that's come up recently during some conferences is, as you know, I've been on a lot of conferences in the last couple months, is this discussion about some of the most common citations. And one thing keeps popping up, and that is if you're looking at the CMS list of common citations, if you talk to state surveyors, if you look at the recent reports from ACHC, Quad A, and AAAHC, one common theme is there. I mean, there's a couple common themes, but one big one, and that is the sanitary environment and infection control. So I thought we would just talk a little bit about that right now. The sanitary environment and infection control issues consistently rank among the top deficiencies in ambulatory surgery center accreditation and certification surveys, making this a real hot issue in the current year and no doubt moving forward. And these citations directly impact patient safety by increasing risks of healthcare-associated infections. And they appear frequently across major surveys such as CMS, AAAHC, ACHC, et cetera. So for context, in AAAHC's 2025 Quality Roadmap, which was released in September 2025, infection prevention remains a persistent top challenge, with deficiencies cited in nearly 90% of surveys for ASCs and office-based surgery settings. ACHC's November 2025 survey data highlights sanitary environment lapses, for example, sanitation issues, incomplete policies, as a leading deficiency, often tied to inconsistent implementation of hand hygiene, glove techniques, and environmental cleaning. And as I've mentioned before, historic CMS data shows patterns holding into recent years, with sanitary environment and the infection control program being among the most cited areas, stemming from failures in basic practices like cleaning, sterilization, and safe injection protocols. And this is always surprising to me because when I walk into a surgery center, they generally look pretty clean, Sue. However, under the surface, we start to see all kinds of problems. And these issues often arise from documentation gaps, staffing inconsistencies, or overlooked details during busy operations, even in those high-performing centers. As we often do when we're talking about these issues, we always want to go back to the key regulatory requirement. The foundation for a sanitary environment and the infection prevention program in an ambulatory surgery center is, of course, the CMS condition for coverage 42 CFR 416.51, which applies to Medicare certified ASCs and influences other accreditors such as AAAHC, ACHC, et cetera. And this is what the standards said. The ASC must provide a functional and sanitary environment for surgical services, avoiding sources and transmission of infections by adhering to professionally accepted standards, for example, CDC, ARN, APIC. And the 416.51b, which is the infection control program, requires you to maintain an ongoing coordinated program to prevent, control, and investigate infections and communicable diseases. And this includes the designation of a qualified professional, i.e., a infection preventionist, to oversee the program, to perform an annual risk assessment to identify infection risks, and to integrate nationally recognized guidelines such as the CDC core practices into your infection control program. And then making sure that you have policies for hand hygiene, environmental cleaning, sterilization, high-level disinfection, safe injection practices, and point-of-care devices. I think this is all very obvious stuff, but it really, perhaps it's so obvious that we forget to go back and look at these policies on a regular basis to make sure that our actual practices match up with what the policies that we've written state. And don't forget that surveyors use tools like the CMS Infection Control Surveyor Worksheet to evaluate compliance through observations, interviews, and records review. And of course, you can get a copy of that Infection Control Surveyor Worksheet right from the internet. Just Google Infection Control Surveyor Worksheet, and you'll be able to pull up the most recent version of it. And AAAHC and ACHC standards, as well as the other accrediting organizations, do align closely, emphasizing risk-based programs, staff competency, and documentation of processes like cleaning schedules and competency assessments. And I can't emphasize enough how important it is to do ongoing, regular competencies on all of your employees, especially in the area of infection prevention. And then to do them again, even if a year hasn't lapsed, if you recognize or see some breaches. So common citation triggers include inadequate hand hygiene or glove use, improper cleaning or disinfection of surfaces, equipment, or reusable devices, lapses in high-level disinfection or sterilization monitoring, for example, missing logs or biological indicators, and, of course, unsafe injection practices such as reusing syringes or failing to disinfect vial septums.
And here are some practical suggestions to avoid citations. To proactively address these risks, focus on building a culture of compliance with these evidence-based tips. So number one, strengthen the foundation of your infection prevention program by appointing a dedicated, trained infection preventionist and update your annual risk assessment to reflect current procedures, volumes, and emerging risks like multi-drug resistant organisms. Base your policies on CDC's Guide to Infection Prevention for outpatient settings and core practices. Number two, prioritize staff training and competency, as John mentioned. Conduct initial and annual competency assessments for all staff on hand hygiene, cleaning protocols, high-level disinfection and sterilization, and safe injections. Use direct observations, not just self-reports, and document results. Surveyors really like to see those documentations. And as you said, it doesn't have to just be initially and yearly. Anytime you see an issue or you have new equipment,
right,
anything like that. And number three, implement robust monitoring and audits. Perform regular environmental rounds and audits. We usually suggest monthly, using checklists for high-touch surfaces, sterile storage, and OR turnover cleaning. Track compliance metrics such as hand hygiene adherence via secret observers. In other words, don't have it always be the same person, spread that task around, and review in quality meetings. Maintain detailed logs for sterilization and high-level disinfection, biologicals, chemical indicators, and maintain logs for your cleaning schedules. And number four, focus on high-risk practices. Enforce single use of needles, syringes, and proper vial handling, like disinfecting the septums, dating multi-use vials. Ensure immediate use steam sterilization is limited and documented appropriately as to the reason why you had to do that. Address environmental cleaning. Use EPA-registered disinfectants. Follow contact times, which is so important. Make sure you have a way of monitoring that there's a clock nearby or whatever that is. And separate clean and dirty areas. And, of course, prepare for surveys. Conduct mock surveys focusing on infection prevention observations and tracer activities. Ensure all documentation is readily accessible, such as your policies, your logs, your training records, and encourage a speak-up culture for staff to report lapses without fear.
Yeah, I think this is all really good advice and a kind of a very succinct summary of what you should be looking for. But as I said, I think sometimes we get very complacent about this, and then really we find centers getting hammered during infection control sections of the survey. And I, as a surveyor, have definitely noted that almost all of the major citations I find during the survey is going to be in the infection prevention area. So don't forget how important it is to do that infection control risk assessment. It needs to be different every single year, because if it isn't different, that would indicate that you're not starting new practices that are actually improving your infection prevention program. And of course, if that's the case, then you do bring it up again in the next infection control risk assessment. But hopefully you're going to find some improvement over the years.
Yeah, and there would always be a note of, okay, we tried this didn't work,
right, and
then we're going to try again. You just don't slide along.
Yeah, and actually that's a very good point, Sue, is that you're not going to be successful in everything that you implement. Your training programs might have to be adapted for your employees depending upon their level of knowledge of ambulatory surgery setting, et cetera. I did want to go back to one thing that you mentioned too, is the importance of making sure that you are using EPA-registered disinfectants, and that you have a list that's been approved by the infection prevention coordinator, and then pass through the Quality Improvement Committee onto the board so that they approve all of those disinfectants that are being used. I, as a surveyor, when I come in, I'm going to look for that list, and I'm going to make sure that anything that I see during my observation is included in that list. And that's a very common problem. And we hope that implementing these steps can significantly reduce citations and improve patient outcomes and streamline survey preparedness. So in our focus segment today, we had a conversation with Bob Lathrop from SIS, and he discussed navigating the complexities of ASC billing and coding. So let's take a short break, and we'll come back with the interview with Bob.
Surgical Information Systems is a proud sponsor of the ASC Podcast with John Goehle. Our award-winning software platform, SIS Complete, is the choice of over 1,000 ASCs. Why do so many surgery centers operate smart with SIS solutions and services? Because modern cloud-based software with modules for inventory, scheduling, revenue cycle management, clinical documentation, patient communications, and analytics, all on one platform, streamlines workflows and delivers data, including detailed case costing, that helps centers run smoothly and stay focused on what matters most: patient care. Efficient, comprehensive, easy to use. That's smart. And it's all backed by an industry leader who has focused on surgical software for over 28 years. To learn how Surgical Information Systems ASC software or revenue cycle services team can help, call us at 800-866-0656 or visit us online at sisfirst.com.
I'm here with Bob Lathrop. He's with SIS, and we're talking today about ASC billing and coding. First of all, Bob, welcome to the podcast, and can you please introduce yourself?
Thank you, John. Yes, Bob Lathrop here. I'm the coding director at SIS. Started with this company late in 2024. Before that, had my own compliance coding and billing company, specifically for ASCs for about 12 years, and have been in the space for quite a while. And yeah, excited to talk with you.
That's great. And, Bob, this is a very much evolving area. AI, of course, has had a big impact on that. Of course, this is an area where my observation is more and more centers are just kind of giving up, and moving in the direction of hiring outside companies to do either the coding or the billing or both. So why don't you start by giving us kind of an update on where the industry is right now, what's going on, kind of the broad spectrum look at the coding and billing in the ASC market.
Well, yeah, there's been a few large changes over the last few years. One of them that you mentioned, AI, has become very relevant in the space when it comes to coding. From that perspective, right now, it's being used as an assistant to coders. It's gotten better and better from a research perspective more than anything else. Less so for being compliant or 100% accurate, but geez, it has made things a little bit easier when it comes to researching things you may not know, coding related. Of course, you always want to back up all of that information with governing body policy, what you know, working with your peers. But it has become quite a large part of the industry within the last year or so. I know optical character recognition has been around for quite a while, and there's a few companies that have worked with that. But when it comes to ASC coding, it's a little bit of a different bag as far as what we're all looking at. There's specialty coders that will only code orthopedics or only code cardiology, something of that nature. But for us ASC coders, we're Jacks and Jills of all trade. Everything comes through the ASC nowadays, and so we have to learn quite a few different specialties. So yes, the AI side of it has been great from a research perspective. Another point to hit on that's been new for ASCs lately is that cardiology and peripheral vascular procedures have started to hit the ASC space over the last 5 years or so. A pain point in that is a lot of ASC coders have not had experience in that type of coding, those types of procedures. So that's a consistent education piece that we work on with our teams to make sure that these things are coming, and they're coming quickly when it comes to the ASC space. So staying up on any new procedures, new strategies when it comes to ASC reporting is paramount for our team.
You bring up a very important point too, as we get into more complex procedures, having good, accurate coding that's both going to maximize your reimbursement and reduce or eliminate risk, that you're improperly coding, really shows the importance of having certified coders, or at least people that have extensive experience in the ASC market. What do you see with that right now? I mean, for example, we still see doctors right now that, insist they don't need to get a specialized coder, or will use the coder from their practice to do the coding, and that really isn't quite advisable, correct?
That's correct. And it is tough. In certain ASCs, you have your accounts receivable representatives, your payment posters, billers, and maybe you have a coder on staff too. But the hard part of being that lone coder at an ambulatory surgery center or multiple coders is you don't have the just connection and network of other teams of compliance specialists to work with that often. It's something where when I've taken different coding positions or worked with different ASCs, I always tell everyone I was probably a bad coder for about 5 years, because you have to take your lumps early on of learning what you're doing right and what you're doing wrong. And as everything continues to evolve from an education perspective, from a policy perspective, staying on top of that is easiest when you do have a network of peers to work with. So working with, there is a lot of outsourcing going on lately. And I think it tends to be a good thing in the ASC space, so that you do have those resources to rely on when it comes to education and compliance.
So let's stick with, for a second, those organizations that choose to do their coding in-house. What would you recommend? Well, first of all, what type of experience would you recommend that a coder have? And then second, how would that coder stay up to date? Because obviously they need ongoing training.
Yeah, whenever I'm looking into hiring coders or anybody for our teams, whether that's a large team of coders or even in an ASC space previously, the unfortunate thing is I do always recommend at least 2 years of very relevant surgery coding experience. There are a lot of coders that have experience in different specialties, but oftentimes it's like speaking a different language.
Yeah.
If I'm a great radiology coder, that lends very little knowledge to surgery coding. And so having that robust surgery knowledge of at least 2 years as a foundation, and more than that, really does help. When it comes to those ASC spaces, insurances have taken over such a large part of what should be coded versus what the AMA says or what Medicare says. And working through those steps of this is the code that we scheduled versus here's what the physician actually performed has become such a larger issue than it was 3 to 5 years ago. So having that knowledge and really being able to back up and support what you're reporting is very helpful from a standard reporting process and the secondary appeals process.
So how do you recommend people keep up to date? What types of resources might be out there, both free resources and resources where they might have to pay or go off site for training?
So as far as free-ish resources, most coders are either certified through AAPC or AHIMA. And those two specialty societies do offer resources if you're part of their group to maintain coding knowledge. They have robust webinars. They each have monthly newsletters that you can work through. And those are great. And I've done a lot of that myself, worked on some of those webinars, worked on some of those resources. However, the frustrating part on that side is some of it can be opinion-based because it's not as well vetted as something like the CPT assistant from the AMA or the AHA coding clinic that really gives more information on the intricacies of coding detail. Each year, there's new CPT codes, revised CPT codes, and deleted CPT codes. And with that, there can be new pieces of guidance that are necessary. We'll get these new codes, and sometimes you won't know whether you can report it with another code based on the AMA policy. And so working with the AMA on that CPT assistant information is very helpful when it comes to coding. And when you work with large groups, you usually have access to that information and you're sharing it and you're working with each other on what you've seen. Whereas if you've got a lone coder at an ASC, they may not have that. It's one of those early coding things that I tell new coders is you don't know what you don't know.
Yeah.
Because it's impossible to know some of these policies. There's hundreds of thousands of them out there. So working with that AMA and AHA information is the best and standard product to use.
Now, you alluded to this earlier, but how important it is for a coder to stay up to date, both with instructions provided by the insurance companies with which they work. And I think you're also referring to the local Medicare carrier guidance.
Mm-hmm.
So again, let's reiterate the importance of that, if you don't mind.
Yeah, it is one of those things that a lot of coders miss because while we're working with our CPT manuals, IC10 manuals, and any kind of policies around that, payers have their own policies as well. And being up to date on your local policies is helpful. There are, of course, more national payers, something like a payer like Aetna or United Healthcare, that really governs stuff on a national level. So that is nice. They'll have established policies on their websites, and those should be known prior to coding. For example, for Aetna, when it comes to a meniscectomy of the knee, they'll only take those procedures if a patient had a traumatic injury. So knowing that documentation on the front end and that, hey, we may have a fight here for this chronic injury is a big thing to know. Back in the 2000s and the aughts, that wasn't as big of a deal. Payer policies did not matter as much. Now, if you must know those on a local level for not only what procedures are relevant to report and diagnoses, but what modifiers those payers may want to see.
Yeah.
And it's at a local level, but also when you work with larger corporations, you're looking at every state. So you need to know from Alaska to Florida, their policies, and just having that information set in stone at your facility really does help alleviate any back-end frustration when it comes to billing denials.
Okay. So when you're hiring somebody, Bob, there's been some discussion lately about testing potential employees that would be doing coding. Is that something you recommend? Is there a particular way to do that if you do recommend it?
It is something I recommend, and it'll depend facility to facility, company to company. I've previously had a very frustratingly hard ASC coding test that would work through every specialty where, as coders, we are expected to be at a 95% CPT accuracy and somewhere around there for HCPCS and IC10 diagnosis codes as well. But when testing a new coder that you're training, of course, they may not hit that amount, but just knowing that they have some knowledge over these extensive detailed cases that can be performed in an ASC is very important. If you're not doing a test to screen out coders, I personally will do a technical interview right away. We'll work with coders on, have you been certified? What specialties are you great in? What's your weakness? But my favorite thing to do is ask coders, what does 29827 mean to you? And if they don't know, then we're at a hard sticking point. A lot of specific questions of, I'm not going to give you all the information, but some of this stuff we need to know off the top of our head to be production coders that are relevant in the space.
So I think as part of any corporate compliance program in an ambulatory surgery center, one of the requirements is that you have periodic coding and billing audits. Let's talk about that coding side for a second. How frequently, or do you recommend frequent coding audits be performed on your coding department?
Yeah, it is a question we get a lot when it comes to new centers that we're working with or centers that maybe their compliance plan could be updated. We do recommend that every surgery center have a compliance plan posted and that compliance plan include their auditing strategy.
Right.
Personally, I've always recommended quarterly audits.
Okay.
One, because then we're not having anything that's past timely filing with payers. We can get on top of any issues that are coming up within that quarter. Sometimes it's 2% of your cases, up to 5%. But anywhere within that space where we're capturing a solid amount of cases per physician in each quarter. Now, I do work with some facilities that want to do these yearly, and that works as well, as long as it's part of your compliance program. But it does lead to some timely filing issues and even patternistic issues where something's been missed 20 times over the year, whereas if we did that quarterly audit, we would have caught it. As far as my internal coding team, we do quarterly audits on them as well. Each quarter, we pick a number of cases. Our team has to hit a certain accuracy metric when it comes to all of their coding, the CPT portion, HCPCS, everything. And if not, they go back under full review with our team, just so we know what we're looking at. On top of that, anytime a coder is working in a new specialty, we do recommend putting them under full audit for that specialty. Anytime they're working with a new center, we make sure that you're under full audit for that center until you hit a certain accuracy metric. And of course, with how healthcare has changed over the last few years and payers getting so involved in auditing on their end as well, we're under constant surveillance. So there is a day-to-day audit going on by every center we work with where maybe it's a billing issue, maybe it's a coding issue, but we are consistently talking about cases and what needs to be rebuilt and who needs to be re-educated.
So, Bob, one of the things that I've always kind of reiterated to people is that these coding audits are not just to make sure that you have coded something improper. In other words, you want to avoid any illegal coding, but also it's an opportunity to maximize or to make sure that you're getting the appropriate reimbursement for the procedures that are being performed. Particularly, as you mentioned, with these newer procedures that are often procedures that coders might not have learned in school or as part of their training.
Yeah, it's not only to try and see, where we're limiting bundling, where denials may happen. It is to maximize reimbursement. We will work with ASCs where when we start these audits with them, we'll say, which of your payers are following strict Medicare guidelines and which ones may be following AMA guidelines. And you'll find certain professionals at the ASCs that don't even know what you mean between the difference. Yeah. And so it is an education piece of, well, we're trying to maximize your reimbursement here. So there's certain disagreements between the AMA and CMS on what procedures may bundle and what may not. So going through that discussion to maximize reimbursement helps. One of the things we have to always make sure to work with when we're doing a compliance audit for an ASC is to talk through their HCPCS reporting when it comes to drugs or implants and whether they've negotiated those contracts with their local payers or even thought about negotiating them. Of course, Medicare and certain payers that follow Medicare guidelines may consider most implants packaged, and that goes for drugs too that are not those K2 drugs. But for commercial payers, it really is about negotiating with the payer on what they can see separately. There are a lot of commercial payers that will reimburse separately for implants, and that's particularly relevant in the ASC space because oftentimes the ASC is purchasing this implant based on the physician bringing a procedure there. And it's imperative that the ASC know that they're going to get reimbursed appropriately, so they're not losing money based on taking the physician's word for it that it's going to work out in a positive way.
So you've made a very strong argument for getting very experienced coders and keeping them trained and overseen. Not everybody's going to be able to do that, depending upon your marketplace, the availability of experienced coders. Your ability to pay for those coders, or maybe even, is it a full-time job, and are people looking for part-time or full-time work? So why don't you give some guidance to our listeners as to when is it probably time to consider outsourcing your coding?
Well, I would say that most coders in the ASC space, when it comes to production coding, where your job is mostly to perform the coding of the case and help out with denials for the billing team, you're looking at anywhere from 60 to 100 cases a day that coder can perform. And on the back end of that, help out with denials, discuss any revisions that may be necessary. If your ASC is not performing 60 cases a day, then looking at outsourcing does tend to be the best bet. Otherwise, you are looking at a part-time coder for the team. And that part-time coder just may not have either the relevant experience or the resources around them to help out to make sure that we're all being compliant. So if you're hitting that, which many ASCs aren't at 60 cases a day, if you're not hitting that amount, I would recommend outsourcing to a team that can help you out where maybe you're paying a flat rate, maybe you're paying a monthly rate, But at that point, you're not worried about the employee perspective of the position.
Now, and of course, you do have a hybrid option too there. In other words, some of your coding can be done internally and some can be done by an outside company. For example, the more complex cases could be outsourced if that's necessary.
Yes, definitely. And I've worked in both capacities, either where a team that's outsourced is taking all of the coding for a center, or the center does have some cases that are maybe a little simpler, maybe they know a lot about, or their physicians really have a great system in place for the coding, where it is a hybrid model. And we've definitely worked both ways on that. And the other thing that I tend to, offer to ASCs is, let's say you do have a great coder on staff, but every once in a while a physician comes in with some very extensive case where nobody at the facility is really clear. As long as you have some sort of communication with an outsourced staff that does have a group of coders, maybe they can help you with those 1 or 2 cases a month to work on education and to make sure that we're all, reporting things appropriately.
I guess what you're saying, just like we have lawyers on call, you're saying that you probably should have some type of a coding firm on call too, just for those difficult cases that might come up.
Yeah, having that relationship at least helps everyone feel like they're doing the right thing and that nobody's guessing. And if we are guessing, at least we have a great team with us that's helping us on the front end to be as correct as possible, and on the back end to work with the payer on what they may want to see otherwise.
So let's talk about some of the challenges that coders have in doing accurate coding. I, of course, am referring probably mainly to our physicians, our dear physicians. Why don't you talk a little bit about some of the challenges that the average coder faces and how best to deal with them?
Part of the frustration on a coding side is coders are considered to be experts in some capacity. However, there are cases that you will have never seen before that come your way. There's new systems like biocartilage that come through where clearly there's no codes that represent it, but you're waiting for the AMA to say, should I code it X or Y? How am I supposed to look at this? And there are times where coders are very unclear on what they're doing. So that can be a frustration. We've had cases where a physician is repairing 7 tendons in a hand or wrist level, but may say, that tendon was repaired at the carpometacarpal joint. Is that the hand or the wrist? Well, I'll give that to 10 different coders, and those 7 repairs may look 10 different ways. So working on those complex cases together can be very frustrating. And then a payer will come back on the back end and say, well, you did this all wrong. But a coder's doing the best they can at sometimes on these complex cases. So that is a frustration in the space. And as we get year over year, new codes coming out always cause compliance issues. So as long as a coder's attempting to do the right thing, staying on top of their policies, and can explain what they're doing, that is the best way to stay relevant in the space and just have success from a frontline level, and from the back end being able to appeal that at least you knew what you were talking about when doing that initial coding.
I think it's important to de-emphasize the ability of a coder to contact or have some contact with the physician who performed the procedure, rather than keeping them in a box and away from that ability to reach out is important too.
I think that's very important as well. And it's important for that relationship to be a positive one, not a relationship where a coder is trying to do something incorrectly for the physician. If we all assume positive intent, that does work out much better in the coding space. The hard part specifically to ASC facility reporting is oftentimes you are in a box away from the physician. They go back to their office and you are relying on the ASC staff to be part of that communication. And there is some, playing of telephone at times when it comes to that. So trying to get that relationship more steady instead of just being through other admins or business office managers at the ASC does really help drive that relationship and make everybody stay on the same page.
So how can technology help the coder in an organization? What's occurring what are some of the new developments there?
Something that's gone on a lot over the past few years is electronic medical record systems or billing systems having the coding specific information housed within them. There's times, back in our younger days when we were coding out of books, putting stuff on a spreadsheet and sending that off for a biller to figure out. Now, when codes are housed within a billing system or can be transferred over, it does make everybody on the back end's job easier after the coders work through it. Outside of that, a lot of what we work with are encoder systems online, and those help put all of these rules that we're working with in a single place. A place where we can check NCCI edits from Medicare, a place where we can look up all the relevant guidance from different specialty societies. Having that all housed in one area has been really helpful over the past 15 years or so. And now, where AI is getting involved with coding, for a lot of coders, that seems like a scary thing, where you're wondering, is AI going to be able to code something soon?
Yeah.
As somebody who works with a few different AI systems, I think we're quite a ways off when it comes to that, but it is now a daily help within the space. Just one other resource of research. There would be times years ago where I'm looking up a cystoscopy with a stent placement and a lithotripsy and a ureter and what bundles, what doesn't, and I'm researching 25 different websites to see, what does the American Urology Association say? What does this specialty society say? AI can help put that all together for you so that you're not doing all the research on 25 different websites. That system is, and you're utilizing that to leverage all of the coding quicker on your end.
You bring up an interesting point, too, because obviously you have the knowledge to know when AI is perhaps giving you the wrong answer or leading you in the wrong direction. I think, isn't it important for, before a coder and a biller uses AI, that they really get thoroughly trained in knowing how to use it properly and how to determine whether that information is accurate?
It is very important because, as it stands right now, it's a great help. It's a boon, but you have to be able to back up what an AI system is saying with some sort of governing body policy, some sort of resource. You can't take it for granted as being correct. And I would say right now, it's a 50-50 shot on whether what you're reading in an AI system is correct or not. So it does involve either A, robust background, 20 years experience in the space, or B, really verifying that research on your own end as well.
Yeah, I just know anecdotally that talking to coding auditors, that those that have been doing coding audits of AI-generated codes have noted that the failure rate is currently quite high still. And
it is. And in the auditing space, it's even more relevant than it is in the coding space, where there are teams of auditors that will use that as a source citation. And as it stands right now, AI is not a source citation that's relevant. You need to look for that governing body policy from specialty societies and the AMA,
right,
and whatever vendors they utilize as their specialists for, their orthopedics from the AAOS, their urology from AUA, things of that nature.
You've referred a couple times, Bob, and I've kind of let it go, to policies and procedures and how important it is to keep those up to date in your organization. I, as a surveyor, often go out on site, and I don't even see policies and procedures for the business office, let alone coding and billing. So can you just talk, briefly about how you would go about that and who should be involved in the process of updating those policies?
Yeah, it's usually a combination of the staff, but it starts with the administrator and the business office manager. And from Medicare, there are specific mandates that you must have a compliance officer, and you must have your compliance policies not only set, but present so that they can be reviewed. So having a compliance plan in place that at least one person in the office can speak to is very important. There are times when I'll go to ASCs as well, and the first question I'll ask is, who's your compliance officer?
Yeah.
And if it's a smaller ASC, they may be looking around at, well, who is that here? But having that information readily known and available is very important, especially if you have an audit coming your way.
Yeah, and let me just add a couple notes from a surveyor standpoint. You really should be appointing a compliance officer in your governing body minutes on an annual basis. And I should also point out that we do recommend that you have a corporate compliance plan. There are some states that actually require that corporate compliance plan, but at the present time, CMS does not require, at least for ambulatory surgery centers. So there is no example plan out there for ASCs, but there are for physicians' offices, hospitals, et cetera, that they can call on. And Bob, lastly, just because you outsource your coding and billing doesn't negate the need for an administrator to keep an eye on what's going on there to make sure that proper coding audits are being performed and that you're watching the numbers closely.
Oh, of course. Third-party auditing teams or outsourced auditing teams should have their own compliance plan and should be auditing their coders. However, oftentimes they need that foundational information from the administrators at the ambulatory surgery center as well when there are contract updates, when there is any changes in physicians that are working with the office. Having that communication in the relationship is paramount, and making sure that those offices, not only, even if you rely on a third party to help you code, that yes, you're checking that information yourself. I always do recommend every ASC perform their own external audits. Yeah. You can rely on your third-party company to do that for you. However, speaking to that on your own does help with not only that coding team learning from your facility, but for your facility to really know on your own end that you're compliant and you have hold over that strategy.
Yeah, and hold them accountable, recognize that competition is very strong in the marketplace for coding and billing, and that your organization, whoever you outsource it to, needs to know that they're constantly being watched to make sure they're providing the highest quality of coding and billing.
Right, yeah, we can never get lazy in this space with how many updates happen. We cannot assume coders are doing their job correctly, nor can we assume billers or accounts receivable reps. Just a consistent auditing plan and knowing that you can speak to it really eases any concern on a go-forward basis.
So in conclusion, do you want to give 3 or 4 bullets for people based on this conversation we've just had?
Yeah, when it comes to coding and billing in an ASC space, some of the most important things are knowing your payer policies, being able to speak to those payer policies and making sure that you have that information readily available. Knowing and having just everyday discussions with your coding and billing teams and making sure everybody's on the same page is very important. Having a very steady compliance plan that the staff can speak to and that consistently stays up to date and is being actioned on is very important. There are times where there's a compliance plan in place, but are we really adhering to it? Yeah. Or has it been a busy quarter? It needs to be something that's scheduled, readily available, and that we're all on top of together as teams, whether internal or outsourced, so that we don't have as many surprises as can come up in the ASC space.
Bob, this has been fantastic. I really appreciate your talking with us today.
Yeah, of course. Thanks, John.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
First of all, I do want to mention that the recording of the 2025 ASC virtual multi-state conference is now available on our website at asc-central.com. So if you missed the conference, you still have an opportunity to get that 16 hours of content, which includes 16 AEUs and 4 IPCHs. So I know as we come toward the end of the year, if you're short on your AEUs or IPCHs, this might be a quick way to get that up to date. So the ASCA and SAMBA Conference and Expo is going to be May 13th through the 16th, 2026 in Washington, D.C. And we will have a booth there for the podcast and for ambulatory healthcare strategies. And I'll be speaking on strategic planning.
And the AAAHCN, or American Academy of Ambulatory Care Nursing, annual conference is April 14th through the 17th, 2026 at the Hilton Orlando in Lake Buena Vista, Florida.
And you want to watch the ASC-Central website as we announce the various conferences in 2026. In January, we'll have our ASC Director of Nursing Boot Camp Later on in the first half of the year, we'll have the ASC Administrators Boot Camp, a one-day Quality Improvement Conference, and a Human Resources Conference. And the dates are not set yet, but they'll be finalized within the next couple of weeks. So for more information, visit asc-central.com. And don't forget, on-demand versions of the ASC Director of Nursing, ASC Administrators, and the ASC Business Office Managers Boot Camps are available on our sister website at asc-central.com. And we always want to remind people to become a patron member. We have over 500 patron members of the podcast. Don't miss out on the benefits of joining the patron member program, available at asc-central.com. This comprehensive membership platform is your go-to resource for all aspects of ASC regulatory and accreditation, compliance, operations, and financial management. It is designed with the busy schedules of administrators, nurse managers, and business office managers in mind. By becoming a member, you gain access to regular Zoom sessions, typically held weekly, and recently they've been either on a Monday or a Friday, where you can engage with other patrons and our podcast team. But that's just the beginning. Your membership unlocks a wide range of resources, including virtual conferences such as our credentialing conference and the Conditions for Coverage conference. You'll also find valuable tools like sample policies, procedures forms, and, of course, our fire and disaster drill kits. Your support helps us to maintain and grow the podcast, covering essential costs like research, travel, equipment, and production. To learn more and to become a member, visit asc-central.com.
Thank you for tuning into this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community and be sure to subscribe so you never miss an episode. We appreciate your feedback and suggestions for future topics. Reach out anytime at comments@ascpodcast.com.
A special thank you goes out to our incredible team, our sound editor, Susan Cronkite, executive producer, John Goehle, and our committed research team of Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Calritis, Jim Masters, Stuart Rosenberg, Amy Cronkite, Lori Rodericks, Kathy Foti, Donna Macchio, Christina Norman, and Katie Pearson. Your hard work makes this podcast possible.
Our theme music is by Media Sushi and Mike Noah. The ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for listening, and we'll see you in the next episode. This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, SIS. SIS's mission is to deliver solutions and services that help surgery providers, regardless of care setting, improve their organization so they can deliver the highest level of care to their patients. For more information, go to sisfirst.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.